ventricular hypertrophy, or LVH, is a very common abnormality. Because of its clinical importance, attempts have been made to develop reliable ECG criteria for diagnosing the presence of LVH in patients. In addition, in some cases, LVH may be associated with alterations to the ECG which are of great significance in the emergency setting, as they are easily confused with the ECG changes of myocardial infarction. For these reasons, you need to ensure that you understand and are able to recognize the ECG changes resulting from hypertrophy of the left ventricle. Looking at this normal ECG, you will remember from section 1 that left ventricular depolarization is responsible for the prominent R waves in the left-sided chest leads and the S waves of the right-sided chest leads. The increased muscle mass associated with LVH produces predictable changes in these deflections, which we will now analyze. And to do so, we will look at the heart in horizontal section, focusing on events in leads V1 and V6. The voltage developed by depolarizing cardiac muscle is proportional to the mass of muscle present. Therefore, as exemplified here in leads V1 and V6, during the process of hypertrophy, as the left ventricular muscle mass increases in bulk, greater depolarization voltages are produced in the thickened wall, and the amplitude of the R wave in the left lateral leads becomes progressively higher, while the S waves in the right-sided chest leads become progressively deeper. Criteria to diagnose left ventricular hypertrophy from the ECG based on the magnitude of these deflections have been developed. These are the so-called voltage criteria, the best known of which is the Sokolow-Lyon criterion. This states that if the sum of the depth of the S wave in lead V1 and the height of the R wave in lead V5 or V6, whichever is the taller, is greater than 35 millimeters, the patient has left ventricular hypertrophy. Let's put this criterion into practice. This is an ECG from a patient with long-standing hypertension. Why not stop the video at this point and see if you can work out the abnormalities present. Try to determine if the patient has LVH and list any other abnormalities or points of interest you identify. The high amplitude R waves in the left-sided chest leads and deep S waves in those on the right are particularly striking and suggestive of LVH. But does the ECG satisfy the Sokolow-Lyon criterion? Well, before applying any voltage criterion, you first make sure that the ECG machine is correctly calibrated. On this particular ECG, a calibration box of 2 large squares in height indicates that a 10 millimeter deflection is produced by a potential of 0.1 millivolts. This is the standard calibration and we can proceed. Now we focus on the chest leads and sum the depth of the S wave in V1, in this case 5 large squares or 25 millimeters, and the height of the R wave in lead V6 or V5. In this particular case, the R waves in V5 are tallest at just over 7 large squares or 36 millimeters, giving us a total of 61 millimeters, well over our 35 millimeter limit. As the criterion is satisfied, we diagnose LVH. But how much confidence can we have in this diagnosis? This is a difficult question to answer, as the results of studies on the specificity and sensitivity of voltage criteria vary depending on several factors. Cardiac MRI data from a cohort of patients with aortic stenosis suggests that if a subject meets the Sokolow-Lyon criterion on their ECG, they have a high probability of underlying LVH on scanning. However, a high proportion of individuals with underlying LVH do not meet the criterion on their ECG. This pattern is observed with all voltage criteria and probably reflects the fact that factors other than muscle mass influence the amplitude of deflections in the leads. For example, in obese individuals, the increased distance of the leads from the heart tends to dampen down the amplitude of the deflections produced. Basically, if the voltage criteria are present on the ECG, this is strong evidence of underlying LVH. However, if they are not, this does not reliably outrule hypertrophy.